دكتورة هناء الفاضل السعيد. هناء graduate from Khartoum University. ما عايزين نقول تواريخ طبعا يا جماعة مع التحفظ، مش كده هناء؟ She's MRCPCH holder in London, having neonatal fellowship, University of Alberta from Canada. She's consultant working now in King Fahd Medical City, and she's the director of the NRP program in King Fahd Medical City. She's a senior consultant and having a lot of work, interested in teaching, and she will present with us and start with us today. And her first topic will be in the Neonatal Resuscitation program, NRP. Welcome, Dr. Hanaa.
السلام عليكم ورحمة الله. شكرا أحمد، جزاك الله خير. Okay, is my screen clear for everyone?
Yes, it is clear, Hanaa. تفضل.
Okay, طيب السلام عليكم. Our topic now will be about neonatal resuscitation, inshallah, and we'll try to go over it in a practical way, and I hope that's going to be beneficial for you in your practical life and in your examinations. The neonatal resuscitation, the NRP is usually, I'm going to go over or will be guided by the American Academy of Pediatrics, NRP. And usually there is the International Liaison Committee on Resuscitation that updates the evidence every 5 years and comes with an update for the recommendations of the neonatal resuscitation. The current resuscitation that people are working on is the 8th edition. However, since the 6th edition, the changes haven't been very major. We will go over the resuscitation based on the 8th edition. Our guideline here would be the 8th edition, inshallah. So the 8th edition has been launched in the year 2020, and many places have started following the guidelines since last year, 2021. So I have broken the algorithm of the 8th edition into steps so that we are going to follow it. We start all the time by antenatal counseling and team briefing and preparing the equipment. So the steps that are done before birth. Usually, you should communicate with the obstetric team to assess the risk factors. You should identify a team leader for your resuscitation team. We should evaluate and anticipate the possible complications and plan how you're going to work through it. Delegate tasks. It's very important for the people who are attending the delivery to have specific tasks. يعني ما ينفع انه فجأة انا هاخد الاير واي، انت هتعمل الكompression، انت هتعمل الاسسمنت. No, we need to be prepared right from the beginning. Try to find somebody to document, because documentation of the events is very important, and gather your equipment and make sure that you have a plan or a way to call extra help. Usually for a normal delivery or for a delivery with no risk factors, so no risk factors, it should be attended by one person who is qualified in providing positive pressure ventilation, and this person should be there just for the soul of the baby, purely for the baby, not to have anything to do with the rest of the team. If there is any added risk factors, you need to have a second resuscitator in the team. If it's a high risk, advanced high risk like prematurity or severe distress, then you need 3 people and one of them should be an incubator. There should always be a qualified person in advanced resuscitation, that is a person who can intubate a baby and who can put umbilical lines or achieve venous access who should be in-house. That person should be inside the hospital, should be just reachable by a call. The normal questions that should be asked before birth, these are the questions that are recommended by the NRP. You should know the gestational age of the baby. You should ask about the amniotic fluid, whether it is clear or no. And you should ask for any additional risk factors. On top of that, you should ask about the plan for umbilical cord management. Previously, this question wasn't there in the 7th edition, and the extra question or the 4th question was number of babies, or is it single or multiple. Nowadays, because there is so much on the umbilical cord management and delayed cord clamping, if we find time at the end, we'll talk about it. People are adding this as an extra question to be planned and discussed before the delivery, and the number of babies is going to be under the risk factor. The equipment that we should prepare for the resuscitation, I'm not going to go deeply into each of them, but you need equipment to provide warmth for the baby. The baby needs to be dried and warmed. You need equipment to help you clear the airway. You need to auscultate. You need to be able to ventilate the baby, provide oxygen to the baby. You need to be able to intubate the baby and give the baby medications. So all the equipment are under these tasks. And as we are going through the algorithm, we will talk about the equipment that is needed. Before we go further into the resuscitation, I want to just talk quickly about the transition from intrauterine to extrauterine life. So this is considered one of the most physiologically stressful periods in the human life, because during this time there is cardiorespiratory transitioning, the baby's lungs are opening, the baby's circulation is changing. Previously, the blood was going from the right atrium to the left atrium, bypassing the pulmonary circulation, and the rest of the blood that goes in the right ventricle bypasses the pulmonary circulation through the ductus arteriosus, and the lungs are filled with fluid and non-functioning. So as soon as the baby is born and the baby cries, the lungs are opened up with air and the pulmonary vascular resistance drops and the blood starts to go into the lungs with the oxygen saturations rising. The fetal oxygen level or saturation levels are much lower than the newborn after delivery. So this high oxygen is going to lead to spasm in the ductus arteriosus, and their circulation is going to be transitioning to our normal circulation with the major and minor blood circuits. The babies are separated from the placenta, separated from the mother. They need to achieve their own glucose and metabolic homeostasis. The babies need to achieve their own temperature regulation, and they need to adapt to their new sensory environment. So this is a very stressful period for this baby at birth. The percentage of babies who need resuscitation at birth. Okay, up to 85% of babies, they are going to breathe spontaneously within 10 to 30 seconds without any intervention. An extra 10%, that is going to make it around 95%, will respond to stimulation and drying. Another 5% that brings it to near the 100% will respond to positive pressure ventilation. So if you are going to a delivery and if you are able to provide efficient positive pressure ventilation, that is just by bagging the baby, you are going to be able to support and resuscitate most of the babies. Only 2% of the babies will need intubation, and only 0.1% of the babies will need chest compressions and medications, which means advanced cardiopulmonary resuscitation. This is according to the latest ELCOR study in 2020. So the next step, now we know the physiology at birth, and the next step, once the baby, once we have collected our team and anticipated and assessed our risk factors before the delivery, after birth, the first questions that needs to be explored, 3 questions need to be answered. Does the baby look term? Does the baby have a good tone? Is the baby breathing or crying? If the answer for all of these questions is yes, so a term baby with a good tone and vigorous crying or breathing, well, this baby does not need any intervention. This baby stays with the mother for the initial steps. The initial steps, which are drying the baby and warming the baby and making sure that the airway is open and there are no secretions that needs to be cleared. Baby should not be taken away from the mother. Ideally, baby should be flipped on the chest of the mother for these steps. If any of these answers is no, that is the baby is not turn, doesn't have a good tone or not breathing vigorously, then this baby needs to be taken to the warmer, which is prepared in the room for resuscitation for the initial steps. So the initial steps of the NRP are warm, dry, and stimulate the baby. Stimulation of the baby is not by shaking. Stimulating the babies in the NRP is by rubbing the feet and the back gently. Okay, please never shake babies. Position the airway so that it is in the what we call sniffing position so that the airway is open. So avoid hyperextension and avoid hyperflexion. Suction upper airway if needed. That is, not everybody is going to need suction. Only babies with secretions in their airway are going to need suction. So if you look here, you can see the first baby is the baby who is in the correct position with the airway slightly extended. The second baby is flexed, where the airway is going to be closed, and the last baby down here is hyperextended. If you can see, when the baby's neck is flexed in the other picture, the colored one, the top one, the baby's airway is closed and the tongue is coming, obstructing the airway. So we want the baby to be like the lower baby in the colored picture. That is to have the airway open. Clearing the airway, as we said, if needed, we should suction the mouth before the nose. Okay, so M before N in the alphabets, because if there are any secretions in the mouth and if you start sucking, then by suctioning the nose, the stimulation might trigger the baby to take a breath, which might end up in aspiration of the secretions in the mouth. So clear the mouth before the nose. Don't go too deep to avoid vagal stimulation. You might need a bulb suction or a suction catheter with different sizes with a source of suction. That could be either on the wall or a portable. The recommended pressures for suction for premature babies are 60 to 80 millimeters of water, and for term babies is 80 to 100 millimeters of water. All our pressures in the ventilation and respiration are usually in millimeters of water, not mercury. So after we have done the initial steps, dry, warm, stimulate, open airway, clear airway, we're going to evaluate and assess the baby again. If the baby is now improving and breathing on their own, then the baby will not need positive pressure ventilation. So if the baby is apneic or gasping and the heart rate is less than 100, this is an indication for positive pressure ventilation. If no, if the baby is having what we call labored breathing or increased work of breathing with cyanosis, this baby is going to need further help by providing the baby with oxygen plus or minus CPAP, which is continuous positive pressure airway, to help and support with their work of breathing, as long as they are having good respiratory effort. Remember, whenever we are giving oxygen, it has to be guided by pulse oximetry and following the targeted oxygenations. We'll talk about that in a minute. If the baby is not breathing well, that is ineffective breathing, and heart rate less than 100, then this is an indication for positive pressure ventilation, which is bagging. If we're doing positive pressure ventilation, we need to attach the baby to a pulse oximeter, and at this time also the NRP recommends to attach the baby to cardiac monitors. Attaching the saturation monitor, usually it is recommended on the right hand of the baby, and the recommendation is to attach the probe to the hand at the last. So attach it to the monitor, switch it on, and then last thing attach it to the hand. This is going to give you better reading and faster reading. Why do you want it to be on the right side, right wrist or right hand? Because it's going to give us the what we call the pre-ductal saturation. Here we see that the ductus arteriosus is joining the ascending aorta or the aortic branch after the branching of the right brachiocephalic. So this blood is not mixed with any deoxygenated blood, and it is going to be reflecting the oxygenation and the saturation of the blood that is going to the brain. We have to follow what we call it the targeted preductal oxygen saturations, which are the physiological saturations at birth. So if you see at 1 minute, it's 60 to 65%. So a baby has the right to be cyanosed at birth, okay? And they will gradually pick up by the age of 10 minutes, they will be 85 to 95%. It is very important to follow these saturation, targeted saturation, because we do not want to deliver oxygen unnecessarily to the baby, because oxygen is a toxic drug. So indications for PPV are inefficient respirations, which are apnea and gasping, and heart rate less than 100. Please remember heart rate less than 100 with inefficient respiration. You can have a baby who is born vigorous and crying and pink and with a heart rate is 65 or 70. This is a baby, for example, could be with a heart block or a cardiac condition. So the baby has to have inefficient respiration to need PPV. Equipment that is needed for PPV are masks with different sizes to fit the baby's size, a source of PPV, and we'll look at that in a minute, a source of oxygen and air, and a blender to be able to control the FiO2 that is delivered to the baby. The kind of equipment that is used for providing PPV in NRP are either self-inflating bag, and the self-inflating bag needs to be connected to oxygen. It could have a reservoir or an open end. The other one is the, so this is the one which is on the two ones. Can you see my cursor? Ahmed, يعني رد علي, is my cursor visible on the screen or no? No?
Yes, it's clear.
Yes? Yeah, okay.
Clear.
So thank you. So these are the self-inflating bags. This is a flow inflating bag, and this is what we call the Neopuff. I'm not going to go into details of this, but these are the equipment that are used to provide PPV. You will use whatever is available in your hospital. Okay. Practical points for PPV, you need to use the appropriate size mask. An appropriate size mask is a mask that covers the nose and mouth without covering the eyes and without going below the chin. You need to achieve a good seal, and you need to deliver the respiratory rate between 40 to 60 breaths per minute. After 15 seconds of starting PPV, you need to stop and assess. Usually we assess the chest rise, sorry, don't stop. You assess the chest rise, the air entry, and the heart rate. If your PPV is not effective, then you need to start corrective steps by what we call Mr. SOPA, and we're gonna go into that. And you have to keep repeating your corrective steps every 15 seconds if you are not having efficiency in your PPV. Efficiency is chest rise and air entry, okay? After you have achieved effective PPV for 30 seconds, then you are going to assess the heart rate and decide whether the baby needs chest compressions or not. We'll go into that. So effective PPV, there is chest rise, there is air entry in the lungs, and improvement in the heart rate. If you get these signs, it means that your PPV is effective. You don't get it, it means that you need to look into it. So this is a picture that is showing the different sizes of mask. The mask that is in the beginning is the correct size. As we said, it's covering the mouth and nose, all of these two. This is called the anatomic mask, and this is the just round mask. So covering nose and mouth, not going below the chin and not reaching the eye. The mask in the middle is too small, and the mask on the top is too big. We want to avoid the mask covering the eyes to avoid pressure trauma to the eyes. And we want to avoid the mask going below the chin to avoid leak. And if the mask is not covering the mouth and nose properly, there will also be leak and inefficient PPV. To achieve a good seal on the mask, you need to hold it in what we say the C and E. So the C, your thumb and index finger should be holding the mask at the base. Avoid holding the mask at the stem. That's not going to give you a firm grip. And the rest of your 3 fingers will be on the bony part of the mandible. Avoid also bringing your fingers into the soft part of the chin or of the jaw, because you are going to obstruct the airway. So C and E, achieve your C and E holding of the mask. Mr. SOPA are the steps to correct your ventilation. So we said after 15 seconds of starting your PPV, you need to start adjusting. And if it is inefficient, you need to adjust. The first 2 steps that you do are the M and R. The M is to adjust the mask, and the R is to position the airway. You should continue PPV for another 15 seconds. During that time, you'll be assessing for the chest rise, for the air entry. If there is no improvement in your PPV, then you have to do the next 2 steps, which are S and O. Suctioning the mouth and nose. Remember, we said mouth before nose, and opening the mouth. You resume your PPV for another 15 seconds. And if by that time, still you don't have a chest rise, you have to increase your pressure. Usually we set our pressures in the whatever equipment we are using at a PEEP of around 5, and which is the PEEP, which is the positive end, expiratory pressure at 5, and the PEEP, which is the peak inspiratory pressure at around 20 to 25, depending on the size of the baby. So we can increase your PEEP, which is the peak inspiratory pressure. So you increase it by 2 to 3 millimeters of mercury. And if that doesn't work, then after 15 seconds, this is an indication to use an alternative airway, which is either endotracheal intubation or laryngeal mask airway. If you're coming to the endotracheal intubation, the indications of endotracheal intubation in the NRP are to achieve effective positive pressure ventilation. So as the last step of Mr. SOPA, before starting chest compressions, if there's an indication to start chest compressions, then it is recommended to achieve an airway. And this has been a recommendation since the 7th edition. If there is prolonged PPV, if you are able to ventilate the baby by bagging and the baby has improved, however, the baby is not having any spontaneous breathing and the baby, it's taking too long, and more than 6, 7, 8 minutes, and the baby is not responding. The reason could be prematurity. The reason could be the baby might be sick, HIE, septic, hypovolemic. So for these babies, you might need to intubate them. And then remember, when you are intubating a baby, that we think about what we call the DOPS acronym. The DOPS acronym has been added to the NRP during the 7th edition. And it is the way to troubleshoot if you are intubating a baby or after you intubate the baby deteriorates. The D stands for displacement of the tube or dislodging of the tube. The O stands for obstruction of the tube. The P is pneumothorax, which are the very big enemy for us in the NICU. The E is for equipment failure. And the S is for stomach inflation. Sometimes after PPV, if the stomach is too full, then you need to deflate it with an NG tube so that it's not compromising the chest. To decide the endotracheal tube size, it depends on the size of the baby. Most people will go by the weight of the baby. So for the baby who is less than 1 kilogram, extreme preterm baby, usually we use the 2.5 tube. Baby 1 to 2 kilograms, we use the 3. Baby more than 2 kilograms, we use 3.5. And for babies who are 3 kilograms and more, you can use 3.5 or 4. So you just go by these sizes. Nobody is using size 2, okay? It's 2.5. So we use up to 4 in the NICU. To decide the depth of the endotracheal tube, there's a formula that is used, which is the birth weight of the baby in kilograms plus 6 centimeters. So if you have a baby born at 24 weeks who is 0.5 kilograms, that is 500 grams, the endotracheal tube needs to go to a depth of 6 centimeters. That is the old formula up to the 6th edition. In the 7th edition, they added another formula, which is the nasal tragus length, the distance from the tip of the nose to the cartilage in front of the ear, and plus 1 centimeter. So this does not cancel the second one. So both of them are working. For best practice, it is advised to do both of them and find something that is between the two. equipment that is needed for intubation. You will need a laryngoscope. You need the different sizes of blades. You need power source for the laryngoscope, and you need an extra power source. You need different sizes of endotracheal tubes. You need measure tape. You need a trocar for the endotracheal tube, which is not obligatory. It is up to the person who's doing it. You need the syringe, you need tape, and you need the NG tube. If you need to empty the stomach, we need to auscultate. And this is a laryngeal mask airway. I'm not going to talk about it during this presentation. And you need also a carbon dioxide detector. It could be calorimetric like this one, we'll talk about it, or it could be what we use, the end-tidal, exhaled end-tidal carbon dioxide that is can be detected by some of the monitors. So depending on the facility that you have. When you're using the endotracheal, the introducer or the trocar, please make sure that it does not go beyond the tip of the tube. It is recommended that it should be just above the side holes, because we don't also want it to go above outside the side hole and injure the airway of the baby. Once you have intubated the baby, confirmation of intubation is by looking for chest rise with the bagging, symmetrical air entry in the lungs, air entry in the chest more than the stomach. Make sure you do that, take both of them, because the baby's chest is very small, and the air entry could be conducted to the chest, even if the tube is in the esophagus. You're gonna see mist or moisture in the endotracheal tube. You have to detect the CO2 in the exhaled air. It could be either by the calorimetric CO2 detector, which could be, which is normally purple, and it's gonna change yellow. Please, once you have confirmed that the tube is in, you have to remove this detector because it increases the dead space during ventilation. Okay, so we have reached the step in the NRP where we have secured the PPV, and we have monitored our air entry with the, monitored our oxygen delivery with the pulse oximetry and the guided saturations. So after achieving that, we need to make sure if the heart rate is still less than 100, you need to see if the baby needs post-resuscitation care or not. Once everything has been achieved and the heart rate is less than 60, so after you achieve 30 seconds of effective ventilation, you cannot do cardiac resuscitation if you have not achieved ventilation. The most important part in the neonatal resuscitation is ventilation, because mostly the baby's issue is ventilation. So if you do not ventilate the baby, you are not going to fix the heart by chest compressions. So after you have achieved ventilation, you give the baby 30 seconds of effective PPV, and then you assess for the heart rate. If the heart rate is less than 60 after effective PPV, then this is an indication to start chest compression. Before you start chest compression, you need to make sure that you have, as we said, achieved an intubation or laryngeal mask airway. You have to put the oxygenation to 100%, and you need to consider putting a UVC at that time, because we are now moving into advanced CPR, cardiorespiratory resuscitation. So you start chest compressions, and the chest compressions, I'm going to go back to chest compressions. Chest compressions, usually you're going to use the 2 thumb techniques. So up to the 6th edition, the method was either the 2 finger or the 2 thumb technique. But from the 7th edition, the recommendation is only to use the 2 thumb technique, because it is more effective in the chest compression, and there is less fatigability of the performer. Make sure, as we said, you put in an alternative airway After 60 seconds, you stop to check the heart rate. In the 6th edition, it was after 45 to 60 seconds. After that, the recommendation was to continue for 60 seconds to allow for more perfusion of the heart. What we are doing during the chest compressions is that we are pumping blood out of the heart and perfusing the heart itself. Because what is happening with the depression of the baby, there is metabolic acidosis, there is decreased perfusion, and the cardiac muscle itself is now depressed and not well perfused. So our primary target is oxygenation of the brain and oxygenation of the heart itself, so that it improves and the cardiac muscle start to pick up and the heart rate improve and the perfusion improve. As we said, we have to go to 100% oxygen, because at that time the perfusion is so poor that the saturations are not reliable in being followed to deliver the oxygen. The rate is going to be usually 90 compressions to 30 breaths. So usually when we are doing the bagging, there has to be coordination between the person who's doing the bagging and the person who is doing the compressions, so that they work together and count together. So it will be 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and so on. So both of them have to be counting together to achieve coordination. By the compression, you need to put your fingers in a line that is between the nipples and the sternum. So in the middle of the sternum, in the midline, the compression has to be deep enough to compress the chest by 1/3 of the anteroposterior diameter of the chest. And you need to allow for chest recoil so that there will be filling of the heart before you do the next compression. At that time, you need to consider vascular access, which could be either with a UVC or with an intraosseous access. Honestly, it's very, very rare to need to use intraosseous access during a neonatal resuscitation, because at birth, the umbilical cord is fresh and not dried. The anatomy is very easy, and it's very easy to access the UVC and enter inside the umbilical vein and enter inside it. This is a picture that is showing the anatomy of the umbilical cord. It is very, as we said, obvious at the beginning, the 2 arteries and the vein. The vein is single, the arteries are 2, they are smaller in size, they are thick-walled, and the wall usually is in spasm. The artery is thin, patulous, and collapsed. So the introduction of the umbilical catheter will be in the UVC, and after you insert it, you're going to just try to secure it on the abdomen with a clear tape or adhesive tape. There is no need to suture it because it's going to be a temporary line. So the UVC that's inserted during the neonatal resuscitation, it's not going to be deep or central UVC. You usually just want to introduce the line up to 2 to 4 centimeters until you just get good backflow of blood. In case there is an issue with umbilical line, for example, if a baby is having any abnormality of the cord, or if it wasn't easy to do it, then you go into the intraosseous line, which is on the medial side of the greater tuberosity of the tibia. And for neonates, you can use a wide bore needle to just go inside it. You don't have to really have an introducer and everything that is needed for older children or for adults for intraosseous line. Medications are the next step. So after doing chest compressions for 1 minute, 60 seconds, and if the heart rate is still below 60, this is an indication to start to use medications. The medications that are used in the NRP are epinephrine and normal saline. Epinephrine can be used even before you have achieved UVC access or vascular access. The preferred route is IV or intraosseous, but however, if you have completed your 1 minute of chest compression and the heart rate is still below 60 and you don't have a vascular access by that time, then the first dose can go in the endotracheal tube. The ETT dose is 1 ml per kilogram, and the IV or intraosseous dose is 0.2 ml per kilogram. Now, this is a new change for the 8th edition NRP. Previously, the endotracheal dose was 0.5 to 1 ml per kilogram, and the osseous or IV was 0.1 to 0.3 ml per kilogram. The new change has been done to just avoid confusion during the preparation of medications and giving orders, and to standardize the care. The normal saline flush that should follow the IV dose is 3 ml of normal saline for all babies, regardless of the size and gestation of the baby. Previously, the normal saline flush was 1 to 2 ml, depending on the size of the baby. This has also been changed in the 8th edition because it was found that you need more normal saline to flush the medicines through the line itself. The epinephrine can be repeated every 3 to 5 minutes, and it is recommended to give a maximum of 3 doses during the resuscitation. The other medication that we use during NRP is normal saline. The dose is 10 ml per kilogram to be given over 5 to 10 minutes. We have to be careful with fluids for premature babies because it can increase the risk for IVH. We need to be more aggressive with fluids for babies that we know are at risk of hypovolemia, like if the mother is having APH or there is any evidence of antepartum hemorrhage or bleeding, then this is a baby for whom you want to be more aggressive with fluids. So we are going to continue our cycles of resuscitation, chest compressions. Every 1 minute or every 60 seconds, we are going to stop briefly to assess and evaluate the heart rate. If the heart rate becomes more than 60, then we have to stop chest compressions and continue PPV. If the heart rate is below 60, we will continue. Every 3 to 5 minutes, we are going to consider giving another dose of epinephrine, and we can also give, as we said, the normal saline if the baby did not respond to the epinephrine. So the recommendation is to stop resuscitation 20 minutes after birth. Okay, if the baby has no heart rate since birth, then you stop after 20 minutes. And this has also been a change in the 8th edition. Previously in the 7th edition, it was after 10 to 15 minutes. The 20 minutes have been put in the new NRP because it was found that many people felt that they did not want to stop by 15 minutes, felt that they need to give the baby more time, and again to also standardize the practice for everyone. This is a very quick summary of the changes of the new of the 8th edition recommendations in the NRP. First of all, we spoke about the 4 questions, that they removed the question of the number of babies and replaced it by the umbilical cord management. And when we need to use then the initial steps, in the initial steps, what they did in the 8th edition, they changed the language. It's still the same steps, but they just changed the language. They recommended to use cardiac monitors whenever we start to intubate the baby or start to do resuscitation. The doses of the medication and the flush of the normal saline have been changed, and the time when to stop resuscitation has been changed. So these are the changes in the 8th edition NRP. I will go very quickly over some special situations in NRP. Extreme premature babies below 29 weeks. Usually we start the initial FI2 at 30% and continue to monitor pulse oximetry. Remember that for full term.
Sorry, Hanaa, you have 5 minutes.
Yes,
so that
I'm following that.
Time for some questions.
Okay. Thermoregulation, babies should be covered with plastic sheet, and we should manage the temperature of the room and put our overhead warmer at maximum. Avoid high inflating pressures, avoid rapid fluid infusions, avoid trundling bear position, which is the legs of the baby being higher than the head, and babies should be handled gently because they have a high risk of intraventricular hemorrhage. Pneumothorax, don't forget pneumothorax during the resuscitation. It's a common complication of positive pressure ventilation. If you are suspecting pneumothorax, please remember to do transillumination and to do needle aspiration. Do not wait for X-rays. Pneumothorax is a clinical diagnosis. Pleural effusion could also be part of the complications in NRP, and you might need to aspirate it in babies with hydrops fetalis. Babies with abdominal wall defects, you need to be gentle with them. If you need IV access, then for babies, the first picture here is the gastroschisis and the other one is omphalocele. So you need to be careful. You need to cover the defect with sterile and moist gauze and protect it. Myelomeningocele babies, if you are expecting a baby with myelomeningocele, you need to prepare gauze in a donut shape and soak it or moisturize it with normal saline to make sure that the baby, if you need to put the baby on their back for resuscitation, it's going to protect the defect. Babies with abnormalities in their airway, like Pierre-Robin syndrome, babies with choanal atresia will need oropharyngeal airways to help them breathe. That's it. I will not talk about delayed cord clamping. I will leave time for some questions.
Thank you, Dr. Hanaa, for this nice presentation. Actually, I'm about to stop you a long time ago, but really I'm interested. I am NRP instructor also, but I'm enjoying listening to the NRP. Thank you, Dr. Hanaa. I will start with some point. I don't know how to manage even in my unit, Dr. Hanaa. For me, myself, when I'm going to intubate any baby, and forget to do the nasal tragus length. Usually remember it after intubation because people will be panic in hurry to intubate, baby is desatting or is not improving, so they are intubating the baby quickly. After that, we remember what is the length of the tube. So I don't know how to make it a habit in the unit, so that I can make it fixed, that to measure before intubation.
I think the RTs should be the ones to remind you, because the RT is going to be the one who's assisting the intubator. We use usually the formula, and this, you can do the measurement, nasal tragus plus 1 centimeter, and use the formula. Formula is the weight of the baby plus 6 centimeters. And normally, yes, not weight the babies. In the by that time, a baby who is born sick, we do not weight them. We just go by estimation.
Yeah.
If you have forgotten to do that, just go by estimation after that and decide the depths of the tube, and just go clinically by the air entry.
Okay. Okay. Please, anyone need a question? You can write it in the question answer, please. So we'll wait for that. We have time to answer 3 to 4 questions if possible.
Okay, I have a question here. When should we start NRP for extreme preterm baby, 22, 23, 24? The answer is it depends on your unit and the viability of your unit. What is the success rate for unit? This is a question that should be answered by the facility. إمكانياتكم شنو؟ 23 ويكر هتعمل له resuscitation. يمكن أنت في مستشفى في rural ما حتقدر تعمل له أي حاجة. If you have the facility and the equipment to resuscitate the baby, resuscitate الgestational age اللي عندكم بتعتبروه viable. لكن internationally والstandard is 23 weeks. Babies 23 weeks and above, 23-0 and above are considered viable. 22 plus 6 are not considered viable. Many places عندك 23 to 25 weeks بيعتبروها borderline viability, and some units will go and do prenatal counseling with the family to decide whether to resuscitate the baby or not to resuscitate the baby, and make a resuscitation plan for the baby. Lakin by the book, viability 23 weeks and above. Most units in the world who have good NICU technology resuscitate from 23. Rarely 22. I see now in Japan Japanese are resuscitating 22 weekers. Some US centers resuscitate 22 weekers. Some people which are very very precious baby 22 plus 5 or 22 plus 6. لأنك أنت دايما بتخط إنه ممكن يكون في حبة error. إذا البيبي size حقه حلو more than 500 you can try to do that. It depends on your unit وإمكانياتكم. دي أهم حاجة.
بالضبط. Just to add, as Dr. Hanaa mentioned, that depend on the unit, your facility, and I know a big hospital here in Riyadh, they transferred for me a baby who is just intubated 30 weeks. They said our unit is level 2 and we can deal with 32 weeks and above. So رحم الله امرئ عرف قدر نفسي. فأنت تكون عارف إمكانياتك، حدودك وين. حتى لو أنا كنت بستقبل مثلا small gestation age ولقيت إنه السرفايفل ريت بتاعي مش كويس، اليونت بتاعتي collapsing, I have to review, sit with myself, with the team and come down. Okay, let us resuscitate for example 32, start 34, then with the improvement.
بالضبط كده، على حسب اليونت.
Yes, exactly.
internationally كثير حاجات بسرعة.
طيب اوكي، انا ما ظاهر عندي.
أنا أيوة. ظاهر شايفة. طيب أول حاجة constant equation for the UVC. في constant equation for the UVC and UAC ممكن أكتبها لكم في الكومنت بعدين، لكن دي ما بنستعملها في ال NRP. NRP low lying UVC 2 to 4 centimeter just enough to get blood back. أول ما جاك blood back طوالي توقف. You don't want it to be central في الدينكافا. You just want it to be تدخلها من الأمبلايكال فين. يا دوب ما دخلت في الدكتس فينوزس. Dose of adrenaline concentration of 1 in 1000. No, the dose of adrenaline should be concentration of 1 in 10,000. اليونتس اللي عندكم الأمبولة اللي فيها 1 in 1000 لازم تحل to dilute it في 10 ml. يعني تجيب الأمبولة اللي فيها 1 ml 1 in 10,000 تجيبها في 10 ml syringe، تاخد عليها 9 ml of normal saline، كده بقت في diluted، بقت 1 in 10,000 وبعدين تستعملها. في units عندهم already 1 in 10,000. It's not 1 in 1,000, it's 1 in 10,000. For the NRP, شكرا. Sorry for not mentioning that. Somebody said oropharyngeal airway in a conscious baby. Yes, في الصورة الأخيرة دي هي oropharyngeal airway. You use it in a conscious baby اللي بيكون عنده good ventilation effort، لكن مشكلته في الupper airway زي بتاع الكوينالتريزيا والبيير روبن. Mr. Sofa, at what stage of resuscitation with the positive pressure ventilation when you are not able to achieve effective air entry? So you keep heart rate less than 60 initial step to start chest compression and confused in point of efficient breathing. Please just explain again. Okay, heart rate less than 60 is not an indication to start chest compression until you have achieved air entry. يعني إذا أنت ما قدرت تخلي البيبي ده تفتح رئته وتدخل فيها هواء، ما في فايدة من إنك أنت تعمل chest compression، لأنه البيبي أصلاً مشكلته هي الأكسجينيشن is poor. لو ما حليت المشكلة الأساسية إنك عملت good ventilation, a chest compression is not going to be of any help. Fix this first, oxygenate him, then do chest compression. I hope إنها تكون وضحت. How to manage coiled cord around the neck of the baby. This is a delivery. دي مشكلة الأوبستريشن، ما مشكلتك. الcoiled around the neck دي الأوبستريشن بيطلع.
manage the baby.
ممكن يكفلوا، أنت بيجيبوا لك البيبي، ممكن يجيبوا لك تعبان، بعد كده هتكون asphyxiated to resuscitate him، لكن ده ما شغلك أنت، شغل الأوبستريشن. How frequent we can give adrenaline for resuscitation؟ قلنا كل 3 to 5 minutes. If you do it every 3 to 5 minutes دي على ما تصل ل 20 دقيقة هتكون خلصت ال3 دوسز حقتك. Indications for endotracheal surfactant. Yes, intubation could be for surfactant. فزول كاتب هل surfactant indication for endotracheal intubation? It is, but not during NRP. NRP we just want to ventilate the baby and do نعيش البيبي يتنفس وقلبه يضرب. بعد كده this post resuscitation sorry care إذا البيبي premature، بعد كده في indications معينة وكرايتيريا معينة للsurfactant administration, and for that time you're going to intubate for surfactant. لكن أنا كنت بتكلم عن NRP. NRP it means during the delivery resuscitation. أفتكر كفاية يا محمد، في أسئلة ثانية.
I think we have a lot of questions but difficult to answer all of it
yes.
now. في ناس بيسألوا من الدوبي وعندنا question بعدين، وأنا حرقت لي بعد الكويشن حاضطر أسحبها لأن شي answered.
ليه ما يرقبوا خلاص هم عارفينها يا أحمد، ليه تحرق عليهم؟
اوكي
في سؤال ولا سؤال مهم، معلش يا محمد، سؤال احمد، سؤال مهم اخير عن الميكونيوم. اسف انا بتكلم عن الميكونيوم هنا. الميكونيوم من السيفنث اديشن you do not have to intubate the baby for meconium. No intubation, just clear the airway زيه زي غيره الميكونيوم. زمان كانت لغايه السكس اديشن لازم انا baby non vigorous baby with meconium you have to intubate the baby and suction for meconium. Okay. I think that will be it for me now يا أحمد. I'll let the next speaker hop in. شكرا لكم.